Okay, cool, guys. So what I want to do now is I want to talk about cerebral perfusion, perfusing the brain, basically. And there's this concept known as cerebral perfusion pressure, or the CPP. And the CPP is a reflection of how well the brain is being perfused. And you guys are probably going to run into calculations. You'll have to actually calculate the cerebral perfusion pressure. It's really easy, though. As long as you can do the mean arterial pressure. So how do we calculate the mean arterial pressure? Systolic.
Plus 2 diastolic.
Plus 2 times the diastolic divided by 3, right? That should be a formula that, yeah, you should just know. Because you're going to run into that one for sure, as we already have. So the first step, is probably what's going to happen is you're going to be given a patient, they're going to give you the patient's blood pressure, and then they're going to give you the patient's intracranial pressure. So we can't know cerebral perfusion pressure without knowing the ICP. And then the only thing that you have to do is calculate the mean arterial pressure, and then you subtract from the mean arterial pressure the intracranial pressure. And that kind of makes sense, right? That whatever the pressure is inside of the brain, you take that away from the mean arterial pressure, and whatever's left over is the kind of the average pressure that's perfusing the brain. Does that kind of make sense? And that is what we call the cerebral perfusion pressure. Just to note, the normal intracranial pressure is about 0 to 15 millimeters of mercury, so it tends to be very low, and that would make sense. We wouldn't want very high pressures there. And your cerebral perfusion pressure, the normal range is about 60 to 90, with about 70 being right in the middle. And what is your normal mean arterial pressure? 60 to 100, right? Oh, look at that. So it basically matches cerebral perfusion pressure, and that makes sense, right? Because your intracranial pressure is generally going to be very low. Okay, so what happens is as my intracranial pressure increases, my cerebral perfusion pressure is going to decrease, right? There's an inverse relationship there. So, what?
ICP decreases?
No. Look at the formula. Just write the formula down. Write it down, right? CPP equals MAP minus ICP. Okay? So imagine that the ICP is increasing, but the MAP is not. It's staying the same. As the ICP increases, what's going to happen to the CPP? It's going to decrease. Does that kind of make sense? That there is an inverse relationship between those two concepts. So if you had to guess, what do you think the body might do to compensate for elevated intracranial pressure? Increase the mean arterial pressure. How do we increase the mean arterial pressure? We have to increase the blood pressure, right? So in patients that have cerebral edema, their blood pressure is often going to be elevated, right? That is a protective mechanism, and this is actually one of the reasons that we talked about back in cardiology, why we don't like to dramatically affect blood pressure in patients. I mean, we talked about hypertensive urgencies and emergencies and those kinds of things, and this is one of the reasons, right? Because if they have altered mental status, you have to put some sort of intracranial pressure problem in your list of differential diagnoses. So, and are you guys familiar with the concept of Cushing's triad? And it is a triad of 3 classic findings associated with elevated ICP. You guys okay with that? And they are increased blood pressure, decreased pulse, and respiratory changes. All right? This is not to be confused with Beck's triad, right? Beck's triad is for tamponade. Yeah, tamponade. That's Beck's triad for tamponade. So this is Cushing's triad. Okay? You guys okay with that? All right. And these three findings, the worse these get, the more likely there is to, the more likely a problem known as herniation syndrome is to develop. And what is herniation syndrome?
When the brain comes through, or, well, specifically, it's when matter comes through something it's not supposed to.
Okay, and when the brain herniates, how does it herniate?
Or there you go.
You guys good with that? Guess what?
Not true.
No. Well, sort of true. Sort of true. Okay, so I want you guys to open your textbook here, and there's a much better picture than I could draw, but I want you to go to page 743. Okay, 743. And at the top of the page, 743, there's this figure 30-11. Okay. What kind of view is this, first of all? This is a what? Is it transverse?
No, it's the.
Yeah. Huh?
No. It's the front and back.
Yeah, it divides anterior from posterior. So sagittal is along the midline, right?
This.
Yeah, mid-sagittal is exactly along the midline. What is, coronal. This is a coronal view. Good. All right. This is like there's that stupid movie I always remember. It's some ghost movie. It's really stupid, but I just remember there's this lawyer walking, and this glass thing comes up. Like this ghost is chasing whatever. This glass thing comes up, and it's the 13 Ghosts. There you go. And then half of his body kind of falls away, right? It's stupid. But that's what I remember when I think of coronal. I just think of, right, that movie. Whatever. It helps me. All right. Don't judge. All right. I want you to look at this coronal view, and I want you to look at the cerebellum. You see the cerebellum there? And then you see the cerebrum, and you see how the cerebrum kind of sits on top of the cerebellum. And do you see the two lines on each side called the tentorium? You see that, the tentorium? And so the tentorium is a shelf of connective tissue. It's an invagination of the membrane of the meninges as they come in. And so you see how they come into the skull like that, or into the cranial cavity like that? And so where is the majority of the brain located? Above or below the tentorium?
Above.
Yeah, this is what we call supratentorial. Do you guys see that there? So if you had to imagine, where do most of your head injuries, brain bleeds, intracranial pressure issues, are they going to be supra or subtentorial in nature? They're going to be supratentorial in nature, okay? So they're going to start above the tentorium, wherever you have your swelling, your bleeding, your mass effect, or whatever, your lesion. So the most common herniation syndrome that we run into is actually the upper part of the brain herniating over that tentorial shelf, okay? So the upper part of the cerebrum actually herniating over the tentorial shelf into the, what lobe do we have here? The temporal lobe, okay, and putting pressure in that area. Okay, that's what we call supratentorial herniation. That is the most common. Less common form of herniation is what we call uncal herniation, where you have the classic brainstem gets herniated through the foramen magnum. Does that make sense? But that's far less common, and does it make sense why supratentorial herniation would be more common? Just due to how much of the brain you have above the tentorial shelf there. Does that kind of make sense? All right. So now the findings are going to be the same. It's somewhat academic at our level where the herniation is occurring, but I just wanted to clear it's a very common misconception up that the uncal herniation is this extraordinarily common problem. Okay. And we'll revisit a lot of this when we go into trauma and we talk about head injuries. One thing that I do want you to throw in the back of your mind is there are some medications that may be helpful in managing cerebral edema, not necessarily hemorrhaging in the brain, but swelling of the brain tissue. One of the mainstay drugs is something called mannitol. Do you guys remember what mannitol is?
Paramedic.
Yeah, and how does it work? It doesn't work in the kidneys, or well, it doesn't have a direct action on the kidneys.
Like permanently pulls it from the cell.
It's what we call an osmotic diuretic, yeah. So it actually pulls fluid out of the cells, kind of dehydrates the cells, exerts an osmotic pressure, right? And blood fluids flow out of the cells. So this is something that we occasionally see used for cerebral edema. What I just want you guys to know that. I also want you to know that mannitol, if you have it, it has some very special storage considerations. It needs to be kept warm, otherwise it will crystallize. And when you give it, it needs to be administered through a filter set. Okay. You guys okay with that?
Are they going to be in the hospital?
Yeah, all the flight crews carry it as well.
That's more critical care medic.
Yeah, I believe, and I'd have to go back on your scope of practice, but I believe it is in the scope of practice.
For interfacility transport.
Yeah, for
monitoring.
It's like blood, you know.
We don't give it, we
Yeah.
just monitor it.
Yeah, once it's been started, then we can.
Yeah.
But they may throw vials at you. Okay, mannitol's going, right, and then you whatever.
That's part of the monitoring.
Yep, there you go. So, again, it's not commonly encountered, but I did want to just point that out because it's like a blood product or fibrinolytics as well, right? We can't initiate fibrinolytic therapy, but once it has been initiated, then we can continue. So there we go. All right, cool. You guys good with that? Okay. So yesterday I talked a little bit about meningitis. You remember that? There are basically two kinds of brain infections that we're really concerned about. There is meningitis, and then there's something called encephalitis. And what is encephalitis?
Causes brain swelling.
Okay, it does cause brain swelling, but what is it?
It's a disease carried by a mosquito.
It's the infection, inflammation of the brain.
There you go. So encephalitis, okay, is a very broad term. That means an infection or inflammation of the brain tissue, right? Meningitis is of the connective tissue that surrounds the brain. So encephalitis is actually in the brain, and there are many, many things that cause it. It can be due to certain viral illnesses, right? Like West Nile virus can have an encephalopathy. And encephalopathy just means a disease or dysfunction of the brain. It's another broad term. There are many different types of encephalitis. Viral, bacterial. It can be due to toxins, heavy metals. It can be due to like chronic injuries, like chronic impacts. You might see in certain sports injuries like soccer, martial arts, football. Okay. So lots of different things can cause encephalitis. And the presentation of encephalitis is a little different, or can be a little different from meningitis, because the brain itself there aren't really pain receptors inside of the brain tissue itself. So the brain is rather insensitive to pain. There's certainly lots of pain receptors around the brain, right, and in a lot of the connective tissues. So somebody who has encephalitis may not have all of the classic pain and discomfort that you might see in someone with meningitis. So what are they going to have? Well, they're going to have a whole variety of symptoms. They're going to have,
Headaches?
They might have a headache or they might not. A lot of encephalitis depends on the location of the lesion. Where is the infection? Has it perhaps formed an abscess in a certain area of the brain? And if a certain area is involved, we'll get more focal findings, right? So you may have like hemiparesis, they may have like a stroke-like, or maybe they'll just have some slurred speech, or maybe they will have the whole fever and and altered mental status and that. The presentation can be very highly varied. Some types of encephalitis only affect certain very specific structures, such as there is a type of encephalitis known as anti-NMDA receptor encephalitis, where it affects the N-methyl D-aspartate receptors. These are glutamate receptors. And it takes those receptors out, and so your patients end up having, kind of they can even become comatose. It can be kind of a real hard thing to work up. So it could be a real tough thing to work up in the field for sure, right? Because you can get these findings that can mimic a stroke in a lot of ways. All right. So I'm not going to expect you guys to be able to identify all the different types of encephalitis and this and that, but just know what it is in general, kind of like meningitis. So you guys okay with that? Does that kind of make sense there? Okie dokie. Let me go back here. All right. So what I want to do now is I want to move on, and I want to talk a little more about stroke. We talked about the large vessel occlusions yesterday. So we talked about the posterior cerebral, the anterior cerebral, the middle cerebral, and the basilar artery. We talked about all those, okay? And those are all what we call ischemic stroke. And what is an ischemic stroke?
The blood is blocked.
Okay, so there's some sort of occlusion. And basically the pathophysiology of an ischemic stroke is very similar to the pathophysiology of a STEMI, or an acute coronary syndrome. You have some plaque that develops, there's some sort of rupture that initiates, initiates the clotting cascade, the intrinsic pathway, then goes into the common pathway, and a thrombus is formed, and that causes an occlusion. There are some other ways we can get it, amniotic fluid, for example. So moms, right, who are in late trimester pregnancies, either before or after they deliver, if some amniotic fluid kind of gets into mom's circulatory system, that fluid can cause a stroke, also cause pulmonary emboli. Fat can also cause strokes. And where do we see this? Well, we see this mainly in trauma patients. Patients who have fractures of long bones where little fat globules get mixed up into the blood and you can get a fatty emboli. So you do have some other ways, but the common presentation of a stroke is somebody who has maybe not known history, but there is a chronic history of vascular disease, and if somebody has peripheral vessel disease, what can you assume? They probably have central vessel disease, right?
Yeah.
And so people who are diabetic, people have uncontrolled hypertension or long-standing hypertension, people that smoke a lot, those kinds of things, all of those risk factors for heart disease are the same risk factors for stroke. You guys okay with that? All right. So that's the ischemic stroke, and guess what? Something like 70 to 80% of strokes are going to be ischemic in nature. So the majority of strokes are ischemic, and there are some therapies that may help, okay? And we talked about this in ACLS, but what is one therapy that might improve the recovery of someone having a stroke? Fibrinolytics, right? Now the window for administering fibrinolytics is different than an acute coronary syndrome, than a STEMI, right? And what is the window?
3 hours.
3 hours from what?
Last known good.
Last time they were known to be normal, okay? Now there are some invasive techniques that can be done under fluoroscopy, kind of almost like a modified cath lab setting where you'd use a fluoroscope or a C-arm X-ray in contrast. You find the lesion in the brain and then you inject fibrinolytics directly into that area. And some of these techniques have extended that time out a little further, but these just really aren't options that we have available. So time is going to be much more critical in a stroke patient for sure. And all of the same contraindications that we see for using fibrinolytic therapy in cardiac patients exists for stroke patients. Hypertension is going to be a big one. Okay, if someone is very hypertensive, and this is the same in cardiology as well, right? If you guys, even in the ACLS video, I believe it was in the ACLS video that the patient was hypertensive and they didn't give the fibrinolytics until they had treated the patient's blood pressure. They got it down, 150 over 100, got it down into that range. So if they are markedly hypertensive, then we'll have to treat that hypertension. Not normal. We don't want a normal blood pressure, but we want to get it under control prior to fibrinolytics. And why do you suppose that is? The risk of hemorrhage is going to be much higher. And make no mistake, the risk of hemorrhage for giving fibrinolytics to an ischemic stroke is what? Something about 5%. I don't know, you guys remember the video, and they're like, oh, it's a small chance, 5%. I'm like, that's 5 out of every 100 people. That's not a, right, that's not I would not call that an insignificant number, right? So can we differentiate hemorrhagic from ischemic stroke out in the field?
No.
We can't. What does a patient need?
CT scan.
They need a CT scan of the head. Now there are some things that may point toward the presence of hemorrhagic stroke. Okay. Huh? Well, yeah, if there's trauma, then we're not talking about a stroke at that point, because stroke is kind of a spontaneous, non-traumatic event. Yeah, it's kind of like if someone is in a wreck and their heart smashed, or their chest smashed against the steering wheel and they had ST elevation, would you say that they were having a STEMI? You'd say no, they're probably like a myocardial contusion, right, a bruised heart. Even though it presents very, very similar, it's a traumatic. Same here, if you have a head trauma, well then, you have some sort of traumatic hemorrhage or something like that. But
Could it still, if you had head trauma and you had bleeding in the brain, would it still present?
yeah, the presentation may be very similar to that of a hemorrhagic stroke. Absolutely. Presentation-wise, yeah, going to be very similar. And really, it's just a matter of cause. What the root cause is, calling something a stroke versus an intracranial hemorrhage or what have you. So things like seizures. So if somebody has a seizure, okay, they have incredibly high blood pressure, okay, those kinds of things point more toward a hemorrhagic stroke. But again, it's very difficult to differentiate or to divorce a hemorrhagic stroke from an ischemic stroke out in the field. Hence the reason we need to get them to an appropriate facility that can do a timely workup on that patient. Now, just like with our cardiac patients that have angina, stable angina, is there a kind of form of angina pectoralis that we see with neurological patients?
Epilepsy.
TIA, right? TIA. And what is TIA? Transient ischemic attack. So it is sudden onset of stroke-like symptoms, but they spontaneously resolve. And generally for somebody to have a TIA, we say that those symptoms will resolve within about 24 hours. Wait a minute. We have a 3-hour stroke window? Yeah. So guess what? It is tricky to divorce a TIA from a stroke, right? It's tricky. We're not really in the best position to do that as hospital providers. But if somebody has a history of TIA, okay, if you have that in their history, their risk of having a stroke is significantly higher than the general population. So the history of TIA is going to be much more concerning. Does that make sense? Because of that correlation.
Now, is there something the hospital can do, like test-wise, to differentiate?
Yes, there are some things that can, MRIs, angiography, with contrast. Yeah, so there are some things that can be done in the hospital to kind of find out, if there is an obstruction, what the blood flow is like, and those kinds of things. Even then, though, it's a pretty tricky situation to kind of work up. There is a lot to
So
it.
they still just do the fibrinolytic therapy? Or
They
would
might.
that be contraindicated for TIA, or?
Well, again, you don't know, right? Because who's going to wait 24 hours?
Right.
Yeah,
That's
so,
why I was wondering if
so what
there's
you're gonna do
tests.
is, you're gonna get that patient to the hospital, and they're gonna do a CT of the head as soon as possible, and then that CT is gonna be read by an expert, right? So a radiologist who knows how to read these. And the official read from that radiologist will guide the clinicians from there, okay? Does that kind of make sense? And generally, what we're looking at is a completely normal CT. If you have somebody that has stroke-like symptoms that do not resolve, real quickly, and you have a normal CT scan, completely normal CT scan, that is good evidence that we're dealing with a stroke over a TIA. But it's tough. It's a real difficult diagnosis to make. So what are some other? And I know I don't have this up here on the notes, but what do you think of some other ways of managing people with stroke? What are some other things that we should probably be doing?
As pre-hospital providers?
Yeah.
Providers in general.
Pre-hospital wise, so packaging, transport, preparing, what are some other things that we need to be
Well,
doing?
low-hanging fruit is worry about their airway, because if they have
Good.
swallowing problems,
Good, right, airway. And what position in general do you think is going to be best for these patients?
depending on if they're alert or if they're awake.
Okay,
Sitting
good.
up.
Yeah, upright position's generally going to be your better, right? Sitting upright, that's good for airway management, right? You definitely don't want them supine, right? You definitely do not want them to be in a Trendelenburg position, right? And potentially increasing intracranial pressure and those kinds of things. Good. Are we going to want these patients on cardiac monitoring? Are we going to want to get a 12 lead? We should be getting 12 leads, yes. Are we going to want to do blood sugars?
Yes.
Yes. Okay, these are standard things that we should be doing. What about oxygen? Yeah, in general, believe it or not, in general, supplemental oxygen is going to, and again, right, we don't want their SATs, at 100%, but we want to keep their SATs in the 90s, right?
About 94 to a little 100.
Yeah. You guys okay with that? Does that kind of make sense? Are there any other specific medications that we can give to them? Not really, no. Do we want to give them anything orally, like aspirin? Why not?
Well,
Well, they may
aspirin, you
not
don't want to
check the airway.
screw up the fibrinolytics.
Well,
We can give aspirin to a cardiac patient who gets
you know,
fibrinolytics.
if it's hemorrhagic,
There we go, right?
aspirin, you're gonna kill the person.
There we go, right? Something like 20 to 30% of strokes are hemorrhagic, right? And we don't know. So that's one big hit against aspirin. The other one is NPO. Do you guys know what NPO means? Nothing per os or nothing by mouth. Stroke patients should be NPO. Yeah, so we shouldn't be giving them anything by mouth just due to the aspiration risk. Good. That's it. And then we need to take them to the closest appropriate facility, and appropriate is the big one there. You guys okay with that? All right. Cool. Airway management, if we have to, right? Do we want to hyperventilate people with stroke?
No.
Okay. No, we don't. Now, when we talk about head injury, there are some heroic techniques that might be considered for people that have Cushing's triad. They're unresponsive, they've got the Cushing's triad going on. We may put them into a moderate respiratory alkalosis. Moderate. We may do that because we do know that CO2 is a vasodilator. It will cause vasodilation, which might increase intracranial pressure, right? And so blowing off a little extra CO2 may constrict those vessels down a little bit, may decrease the ICP. But again, hyperventilation can also increase ICP, right? It can decrease blood pressure, which will decrease MAP, right? Which will decrease cerebral perfusion pressure. It can also alter hemoglobin, right? Hyperventilation can... Right or left?
Right.
So alkalosis will lock, right? Alkalosis is lock. Left shift, yeah. Right shift is acidosis, right? Release, yeah.
For some reason, I keep saying
Yeah.
R for retain.
Yeah. I just think of release. R for release, L for lock. Lock and release. Is that, yeah. So, yeah. And we'll talk about that in trauma, because that's where we see it is traumatic head injuries and not necessarily these non-traumatic issues. Okay, you guys okay with that? Mm-hmm. All right. Gastric intubation. Might we want to consider gastric intubation to prevent aspiration?
Awesome.
Yes, but again, that, you want to do it in a way that, if you're going to do it, you want to do it very carefully. You want to minimize the patient discomfort, right? Because you don't want to increase that ICP. You guys good with that? Now, if you have to transport them supine, maybe they're unresponsive and you're bagging them, what other things could you do to kind of help facilitate or minimize the impact of the ICP? Could you still elevate their head?
Yeah.
Yes, you could elevate their head a little bit, right? Elevate the head of the stretcher, even if you have them generally in a supine position, you could still elevate that up a little bit, right? To kind of to maximize the venous drainage of the brain. Okay, good. What about temperature? Do we want to monitor and control temperature? Yes, absolutely, right? Particularly fever, right? Fever can be devastating for somebody who has a head injury, right? Because it's hypermetabolic, puts you in a hypermetabolic state. And if your brain is not getting the oxygen it needs, okay, making it very, very hyperthermic is definitely going to compound the situation, right? So you want to maintain a normal body temperature as well. Okie dokie, you guys?
What would we do if they have the fever, to just like turn the air on? Or?
Okay, yeah, turn the air on, carve them off, maybe even ice packs, right?
Armpits.
Yep. Yep. Prevent shivering as well. You don't want them to shiver, yeah. So you do want to try to maintain temperature the best you can. All right, Tylenol. We don't have the ability to do that in the state of New Mexico. We can only give that to pediatric patients. But we haven't. Okay, you guys good with that? All right, so there's our stroke. So the big thing is recognizing it and getting into the appropriate facility. Okay. I believe the book then moves on to talking about seizures. And we'll talk about seizures. So seizures are also known as, a seizure is known as an ictus or an ictal event. Okay. And seizures, where do they start? Where do they start? In the brain. Good. And there are two general flavors of seizures. There are what we call partial seizures, and there are what we call generalized seizures. And if you had to guess, or if you did the reading, what is the difference between a partial and a generalized seizure?
Partial is focused on one part of the brain.
Good.
And it affects a single part of the body of some sort. Like
Good. So focal.
Yeah.
We're talking focal findings here. Okay, hyperfocal. Versus generalized seizure, which involves both hemispheres of the brain, right? Yeah. So the manifestations tend to be systemic. Does that make sense? So when we look at partial seizures, you've got several different types, but there are two major types that are mentioned. There are the what we call the simple partial and the complex partial. Okay. And the simple partial seizures tend to tend to be very specific to a part of the motor area in the frontal lobe. So these tend to result in focal motor findings, okay? So maybe somebody just they get some twitching of their hand like this, right? And that's the only finding, is that. Are you guys okay with that, how that's a focal finding? Okay, all right. So they can get something like that, where you just have this focal motor finding that occurs. Now, a complex partial seizure is a little different in that it may also involve the temporal lobe, okay? And there is an area kind of at the temporal parietal junction, which is very important when it comes to consciousness. And we know if there's seizure activity in that area, or if we stimulate that area, that can result in very interesting behavioral changes in our patients. So somebody can have a sudden change in their behavior, not necessarily like a loss of consciousness, but they can just begin acting really bizarrely all of a sudden. And then when the seizure goes away, they go back kind of to their baseline, okay? So if you have somebody who is acting weird and you think, well, maybe they're on a drug, right? You go through the low-hanging fruit. Well, maybe there's a drug involved. Maybe their blood sugar's low. Maybe they have an infection. Maybe they're hypotensive. Maybe this, maybe that. One of the things you also want to think about is maybe they're having a seizure, particularly a seizure that can involve the temporal lobe. In fact, we've been able, using magnets, to stimulate the temporal parietal junction in people, and we've been able to induce near-death experience phenomena by using magnetic fields to stimulate that area, and it can cause like out-of-body experiences and near-death experiences, religious experiences, those kinds of things. What's that?
I said, wow.
Yeah. There's a.
Sign me up.
Yeah, there's is it at Cornell? Where they have the helmet, I think they call it the helmet, where you can go in and you put on this little helmet, and they apply magnetic fields to your brain, and they can, in a large number of people, they can induce these mystical kinds of experiences by stimulating areas of the brain. Yeah, really interesting. But it does go to show you just how important the brain is when it comes to consciousness. Now, like I had mentioned yesterday, we do not have a theory of consciousness. We don't. And when I first started learning about this, I thought, well, that's silly. Of course we do. It's all neurons, right? It's neurons doing their thing, and that. The problem there is when you guys think about physics, you maybe think about like pool balls or billiard balls hitting each other and bouncing around, right? Like particles kind of bouncing around. And when you talk about the brain, it's a lot like that, right? They're chemical reactions, stuff bouncing around. But when you see pool balls hitting each other, do you associate that with anything being conscious, like the lights being on, like there's some conscious experience when pool balls are smacking into each other? Does anyone, honestly Yeah, it's just kind of this stuff going on, right? All it's all of these interactions and all of these reactions occurring, right? Well, that's essentially what we see in the brain, are all of these chemical reactions occurring, right? How is that any different than billiard balls? I mean, okay, so there are trillions of connections, but you could imagine trillions of little billiard balls or trillions of particles all moving around and interacting, some real complex system. But does that necessarily mean that the lights are on there? Not necessarily. So we don't know. There are some theories. Probably one of the most common theories is something called an emergent property, and we talked about this in pathophysiology, if you remember. You can have these properties emerge as certain systems become more complex. For example, I take an oxygen atom And if a hydrogen atom bonds to the oxygen atom, what happens?
Just one?
Yeah, just one.
It's a hydroxide?
It's a hydroxide molecule, right? But is there something interesting that happens with that molecule?
It wants to grab another one.
Sort of, yeah. So the electrical charge is more concentrated on the oxygen, right? Because it's electronegative. And so it makes a polar molecule. And then you can imagine that if I had another hydrogen, I could make a water molecule, right? So if you look at just one water molecule, is it really interesting? Well, not really. It's polar, right? But what happens when you put lots of water molecules together?
They all clump together.
Then they start interacting due to their polarity. And what happens? Oh, hydrogen bonds develop, and the hydrogen bonding emerges out of these water molecules being near each other. And then you can imagine putting other molecules in there, maybe lipid. Maybe you have a bunch of molecules that are, one side is a lipid, so one side's hydrophobic and one side's a salt, hydrophilic, and then what happens? They self-arrange themselves into little spheres, right? Where the outer part, the outer part moves toward one type of molecule, the inner part toward another molecule, and then you have this self-arranging kind of thing that emerges out of that. So that's one line of thinking, that it could be an emergent property of these systems becoming more complex. Another thing that people looked at is actually microtubules is one of the more contemporary things. It has obviously microtubules inside of the neurons themselves and in quantum superpositions, things like that. But at the end of the day, we don't know. It's just a big unknown, and we haven't been able to make that step from all of this stuff happening to, well, how are the lights on, right? What's going on there? We don't know. And it's possible we may never know, right? Because when some of the biggest things we've learned about the universe, we've learned by kind of separating ourselves somewhat from it and looking at it more objectively. And how do you step outside of your own brain? It's kind of a hard thing to do, right? And our brains they didn't evolve to figure these kinds of problems out, right? I mean, we've done a remarkably good job of figuring problems out, but they just didn't evolve to figure out. We ran away from tigers and stuff, right? I mean, that's right. That's kind of what we're hardwired to do, and not necessarily think about what consciousness is and how it emerges from ours. But anyway, that's more philosophy at this point. So let's get back to seizures. So let's now talk about generalized seizures, and these are seizures that involve both hemispheres of the brain. And so guess what? The manifestations tend to be global, right? And the classic form of a generalized seizure is something known as a tonic-clonic or grand mal. And this occasionally comes up, but I want you guys to be able to tell me, what is the difference between tonic and what is the difference between clonic?
Clonic is the body.
Tonic is.
It said-
One of them's.
Read the book. It says in the book.
Is the body's going in ridges.
What's that?
They stiffen up and they lose consciousness during tonic, and then they start jerking with clonic.
Yeah.
So tonic is like a tonic muscle, right? So you get contraction, and that is generally followed by altered level of consciousness, okay? And then the clonic phase is the spasmodic movement, the spasms. All right? And your patients can kind of rotate in and out of the tonic-clonic phase, right? So they'll stiffen up, become unresponsive, or their mental status will be very altered, and then they'll go into the spasm phase, and then they may go back into the tonic phase, and so on and so forth, okay? That is a classic, what we call grand mal or tonic-clonic kind of seizure. You guys okay with that? Another form of generalized is just the tonic seizure. So just the contraction in altered mental status. They can also get clonic or what we call myoclonic. And myoclonus is just muscle spasm, right? Myoclonic activity, all right? You can get something called atonic. What is that?
Without contraction.
Right, so they just become basically unresponsive, right?
Isn't that the one where they just space out,
Yep,
right?
yeah, they just kind of,
Just kind of stare off like you're dating.
Well, I do that all
There
the
you go.
time.
Yeah.
Seizures.
that's just because I'm a boring lecturer.
No, it's not.
Yeah, that's because I'm boring. Yeah, doesn't have anything to do with you having a seizure. Hopefully not, yeah. You can also get infantile seizures and febrile seizures, which are kind of tend to present with this tonic-clonic type of activity. Now, another thing with generalized seizure is there sometimes an event that precipitates the seizure? Yeah, they get an aura. Yeah, they get some weird sensation, a funny smell.
The febrile's usually throwing a kid into a tub.
Yeah, throwing them into a tub and yeah.
They're like,
Yeah.
oh, he's hot, throw him into an ice.
Yeah, that may precipitate.
I
Yeah.
freaked out. My daughter had a fever, and within like 20 minutes, it went from no fever to like 104, according to my thermometer. So I freaked out.
Throw her in a bath?
I did not. I drove her ass to the
Okay.
doctor,
Yeah.
and my batteries were just dead in my
Yeah.
thermometer.
And there is this
She was gonna, like, shake
yeah, and
my
what causes
right?
febrile seizures?
It's a rapid change in temperature.
So is that what you guys are all taught? This is a rapid change in temperature?
Right, that's why I
I'm
said,
assuming
like,
that's incorrect.
it was.
Guess what?
Is it?
No,
Another scarecrow gets lit on fire today. We don't really know.
It just happens.
Alright.
We really don't know. Is it how quickly? Maybe, maybe not. You know, there aren't robust studies done, right? There's not a paper that I can point you to. We don't know, okay? We don't know. We do know that in general, febrile seizures are
temperature-based.
Right.
happen when the temperature is elevated for some reason, and usually they're okay, right? Usually they're okay.
They go away usually too, right? It's
Yeah,
like a-
they're pretty self-limiting, yeah. You generally don't have long-term seizure disorder result from these, anything like that. What is the most common seizure disorder that we run into? Epilepsy. And guess what? Epilepsy is not one problem. Epilepsy is a broad term for a variety of seizure disorders.
It's like an umbrella.
It is. It's an umbrella, just like a lot of these terms are, real broad, umbrella-like. Okay? So, how do we treat somebody having a seizure?
Protect their head.
Protect them first of all, right?
Clear everything away.
Protect them, clear everything away. Okay. Do we want to cram something in their mouth so they don't swallow their tongue?
No.
If you really, really want to lose
If you want to lose a
Yeah.
finger, maybe.
Can you swallow your tongue?
No, it's freaking attached to
No.
your...
Yeah, it's attached to your body. You can't swallow it. Now, you can bite chunks of it off and it can become an airway obstruction. But in general, you don't mess with them, right? You let them seize. Good. All right.
Hypoxygen after.
Good.
Will stick, will stay.
Good. Right. Monitor them. And now let me ask you guys, are you going to be able to get vital signs while somebody is having
No.
generalized seizure activity? You can try, right? But let's be honest.
Try and get
You're
the
just gonna let them see.
Yeah, you're just going to clear the area, make it as safe as possible for them, right? Padding if you can, allow them to seize. Most patients will stop after a couple minutes, right? And then they'll go into what's known as the post-ictal phase or post-seizure phase, where they tend to be confused out of it. Occasionally they may get aggressive, but generally not.
That's primarily just because of little...
They just get scared.
Yeah, they're just, they're scared, maybe a little hypoxic, whatever, right? So good, yeah, so we position the airway. If you want to insert an adjunct, what kind of adjunct's probably going to be the safest? Nasal airway, an NPA. Suction if needed, give them oxygen, right? And then you can go ahead and get them on the monitor, get a baseline set of vitals. What if somebody seizes, they go into a post-ictal phase for a few minutes and then they start seizing again? What's that? That's status epilepticus, right? That is basically having seizures without properly transitioning through the postictal phase, right? So if they have a seizure and they don't ever go back to their baseline, we say that they're in status epilepticus. How do we treat somebody in status?
We gotta stop the seizure-like activities, but we can't terminate the seizure itself. We just gotta be able to ventilate and oxygenate.
We've got to stop the seizure. Benzodiazepines.
But
Yes.
those don't actually stop the seizure, they
Yes.
just stop the muscle tremor.
No, they do. Benzos do, yes.
They actually stop, the book
Yes.
says it doesn't actually stop.
No, you're thinking of paralytics.
Oh, okay.
Yeah. And actually, I have that as a little note down there at the bottom of my notes. So there is this false thinking that, oh, if somebody's seizing bad enough, I can do an RSI, and I'll give them a paralytic, and then they'll stop twitching. But where does the seizure originate?
Right.
The brain, right? Paralytics don't work on the brain. They work on the neuromuscular junctions, but not the synapses in the brain, right? So we need to give drugs that make neurons less likely to depolarize. And what are the ones? The benzos and the barbiturates, right? The benzos are the frontline meds. So diazepam, lorazepam, and midazolam. All right, Valium, Ativan, or Versed, which I don't believe you can actually get Versed in the United States anymore. I believe that the trade expired and it's all pretty much midazolam now, but there you go. Now, I do want you guys to know the doses. So what's your standard dose for diazepam? 5-10 milligrams. Lorazepam, 2 to 4 milligrams. Midazolam, 1 to 5 milligrams, okay? Which one tends to be the longest acting? Nope, lorazepam. Lorazepam has the longest duration of action, several hours. Followed by diazepam, followed by midazolam. So midazolam has the shortest duration of action, okay? Diazepam has fallen out of favor somewhat in a lot of protocols, and a lot of people are now using either lorazepam or midazolam. And midazolam is now a common med that patients have, or their families have, and it can be administered via a MAD device. Are you guys aware of that, right? It can be administered intranasally, like 5 to 10 milligrams intranasally to terminate the seizure.
Do you say the dose for midazolam is 1 to 5 milligrams?
IV, okay?
Okay.
Do they have to wait, the family members, till they're done seizing, or can they do it?
No, they'll do it. Oftentimes, they'll just do it if the patient seizes, they'll just boom, hit them with the midazolam. Yeah.
Is it IM as well, or only IV on that one?
All of these can be given IM,
Okay.
but midazolam is the only one that can be given intranasally, right? So you wouldn't want to do that with diazepam or lorazepam, okay? You guys cool with that? So these are your frontline agents to stop the seizure. Now, in some cases, the seizures will not stop with benzodiazepines, and then we move on to barbiturates. Because interestingly enough, benzodiazepines do not directly affect the GABA receptors. They make the GABA receptors respond more vigorously to GABA. So if you have a situation where someone is GABA depleted, benzodiazepines won't work very well. And there is a situation that we might run into here in Las Cruces due to its proximity to a very special facility just up the hill.
What's that?
The White Sands?
Even before White Sands.
Special.
Yeah, they have their own fire department.
Oregon? Oh, NASA.
NASA,
Oh, yeah.
right? Because what do they do there at that NASA facility? Okay, they work with rockets and satellites, and these rockets and satellites can contain a fuel called hydrazine. And if somebody gets exposed to hydrazine, one of the things hydrazine does is it depletes you of GABA. And so when they start having seizures, these seizures will not respond to benzodiazepines. Okay, they won't respond to benzos. So something to remember. So benzos don't work, then we move on to barbiturates. Your primary barbiturate will be phenobarbital, or luminol, okay? And then at that point, we can look at RSI, right? Because induction agents are very potent anti-seizure drugs. So things like propofol, for example, or diprovan, is very good at stopping seizures, believe it or not, okay?
What did you say the name of
Ketamine
the barbiturate was?
Huh?
Ketamine.
Yes.
I'm not sure so much about ketamine and being anti-seizure.
So it's not RSIing, it's you're given a medication, but you're like, oh, I have to control the airway after that.
Yeah, so you definitely will. And once you RSI somebody and you give that paralytic, you don't know if they're seizing or not, right?
Right.
So guess what? You need to get them to the hospital and you need EEG monitoring, right? That monitors the electrical activity on the surface of the brain, the EEG. It's electroencephalogram. Instead of cardiogram, it's encephalogram. You guys okay with that?
Barbiturate?
Phenobarbital.
Oh, yeah.
Yeah. And then suppressive therapy. Once we get the seizure under control, we'll give medications to prevent seizures from occurring. And the two big ones are Dilantin. It's also known as phenytoin. We generally load them with 20 milligrams per kilogram, and then we'll run that infusion at about 50 milligrams a minute.
Sorry, Chris, Ron Herring brought a truck. There's a unit out there.
Oh, cool.
Want to go through it? It's up to you.
Okay, cool.
Business stuff, so
Okay, thanks, man.
he'll be here as long as he doesn't get a call.
Oh, cool. Appreciate it. Or a medication called fosphenytoin or Cerebral, which is just it's a prodrug of phenytoin, so it's basically Dilantin. All right. I do want you guys to be aware of seizure drugs. These are drugs that patients with seizure disorders are commonly prescribed. All right. So if you see this in the med list, these point to a seizure disorder. These are some of the most common ones. So carbamazepine or Tegretol, phenobarbital or luminol, valproic acid, also known as Depakote, lamotrigine, also known as Lamictal. That thing there, I call it's Keppra. That's the common Keppra. Keppra. Vinyl GABA, which is a pro-GABA vigabatin. This monstrosity there as well. Ethosuximide. I think it's ethosuximide as well. Now, some of these drugs are better at treating simple or partial seizures, and some of them are aimed at treating generalized seizures. And there's actually, I believe, a table in your book where it differentiates which drugs are more for generalized and which ones are more for partial.
Yeah.
Okay, cool. So you can reference that. I do want you to be aware of phenobarbital. We don't see this used as much anymore because it has lots of interactions. And it's really good at interacting with our liver enzymes, and this is the cytochrome P450 enzymes, and there are lots of enzyme induction that occurs. That phenobarbital can make enzymes work better than they normally would, and that leads to just a massive amount of drug interactions. So we tend to stay away from the phenobarbital because we have better options that don't have as many of those kinds of side effects. All of these will have side effects though, right? They can all make you feel drowsy. Dilantin, if somebody's on Dilantin, it can cause their gums to overgrow. Okay, so there are all kinds of weird side effects associated with these anti-seizure drugs as well.
Like overgrow to cover your teeth or?
Yeah, overgrow, become lots of tissue. Yeah, it can be a real problem, yeah. So, bum deal. So you don't have to know like the pharmacodynamics and kinetics of these drugs in any detail, but you should be able to say, oh, this is a drug that if I see this in my patient's drug list, this is a seizure drug, right? This patient may have a seizure disorder. That's really what's important for us to know at our level. All right, guys, take a little break. I'll see you back in 10 minutes. All right, so here we go. Right along. I believe the next major section, actually, I believe that the book also talks about syncope real quick. And what is syncope? Yeah, that's passing out basically. And you can have what's called a syncopal episode and a near syncopal episode. When it comes to syncope, many causes. Just think of AEIOU tips. Syncope is not necessarily neurological in origin. It can be cardiogenic. It can simply be due to dehydration. It can be effects of drugs. So if somebody has a syncopal episode, guess what? That's kind of like abdominal pain. There are a whole lot of things that could be causing that, and a whole lot of them may very well be idiopathic, where we don't have a clue what's going on there. So if you have a syncopal or near syncopal patient, guess what? You want to do your full neurological workup. You better get a BGL. You better get a 12 lead on them. And anybody that has any syncope or stroke-like symptoms, another thing that I would really recommend you guys do is listen to their carotid arteries. Okay? So what should you hear when you listen over somebody's carotid arteries?
It's two, no?
Yeah, you're probably going to hear some tracheal sounds, right? Tracheal air, and that's about it. When you listen over someone's carotid artery, you should not hear rough pulsations. And if you hear that, that's something known as bruit. Okay, I believe it's B-R-U-I. Bruit. I believe it's spelled brutes. And what that is some sort of growth or occlusion of the carotid, and then the blood, as it flows through that occluded or partially occluded area, becomes very turbulent, and it creates this bruit that you can hear. And that it can actually be a risk factor for stroke, because little pieces of that deposit, that plaque deposit, can break off and go into the brain. So that's something that you can do if you have a stroke-like presentation or syncope or near syncope or anything like that.
So you should not hear like a...
No, you shouldn't. You're going to hear tracheal sounds from your trachea, but you shouldn't hear the bruit there, over the carotid arteries. Yeah, you shouldn't hear that.
Didn't you say the other day, when you were talking about syncope, that we should always suspect hypoxia?
Yes. Yep. Hypoxia, hypovolemia. You can do something called the TILTS test. Remember we talked about this in cardiology. What is that? It's orthostatic vital signs. Yeah. Might be helpful as well. Okay. Let's see here. Moving right along to, actually there is something in the, I don't think the book covers it, but it's something called vertigo. What's that?
It's where you get really dizzy.
Yeah, you feel dizzy, right? Lots of things can cause vertigo. That feeling, it can be related to substances or drugs, prescription and illicit. It can be due to something as simple as dehydration. It can be due to inner ear problems in a lot of cases. There's generally it's a viral infection of the cochlea, right? Called the labyrinths of the cochlea, called labyrinthitis, that can cause very severe vertigo. Tumors occasionally. If you get a tumor, particularly a tumor of the acoustic nerve, it's called an acoustic schwannoma, that can cause dizziness as well as tinnitus. And what's tinnitus? Ringing in the ear. Okay. So again, vertigo, you're going to work up pretty much the same as syncope, right? Cover all your bases, but oftentimes the cause is going to be difficult for us to figure out. There is a common cause of vertigo called benign postural vertigo, or BPV, and we think that this is due to little calcifications that occur in the semicircular canals of the cochlea, where your balance and equilibrium comes from, or where information is sent to the auditory nerve, and these little calcifications can kind of break off and cause problems. Generally, that tends to be self-limiting, and there are actually some maneuvers that we can do, not us, but the physician will do, kind of move the patient around and get those deposits in other areas where they are not as problematic. You may see nystagmus, when you move your patient into certain positions with benign postural vertigo, you actually may see nystagmus develop as they move into different positions, and that may point more toward this benign postural vertigo. But in most cases, we're going to have to assume a non-benign cause, work them up, and then transport them appropriately because it's really hard to differentiate. You guys okay with that?
Phobias.
Huh?
Phobias.
Fear?
Yeah, I've seen people pass out needles.
Oh, yeah, so that's called, psychogenic syncope. Yeah, it's called psychogenic syncope, and yeah, that does occasionally happen. Or with needles, that's where they actually vasodilate. They have a large vagal response, right? And they kind of dilate. They kind of dilate out. Their heart rate decreases, and they can pass out. Yeah. And if that's the case, well, that's just supportive care, right? And they generally come along.
Went to a.
Right, when you're doing your IV and they pass out from that, and you can clearly identify, oh, this is a psychogenic type of.
Get your IV and then wait for them to wake up.
There you go.
I went to a cancer center where a lady, the doctor's gonna put her in a CT scan, and she's like, I'm claustrophobic. She said, okay, well, let's do it. And she passed out when she put her in there.
Yeah, it happens. Yeah, it does. Let's talk about headache, because this is a common complaint, very common problem. And headaches can be very benign, or they can indicate very severe problems and can be hard. But in general, there are 4 different types of headaches. So what are they? What's one?
Cluster.
Well, cluster is a subcategory of one. Migraine is a type of one. So there are 4 major types. Vascular. Vascular headaches are related to vasodilation and constriction and generally involving the scalp and some of the deeper vessels, okay? Vascular headaches tend to be pretty severe. The pain tends to be severe, and this is often when we call a migraine headache, okay? Migraine headaches often fall under the umbrella of the vascular category. These patients can get nauseated. They can even have visual disturbances with their vision. They can be photophobic. What is that? Photophobic. Light sensitive. Okay, good. And they can even develop what are called cluster headaches, where you have this clustering of pain. Cluster headaches may be more specific to one side or the other side. Okay, and cluster headaches, a type of migraine, tends to be more common in women than men. Okay, but these tend to fall under the umbrella of vascular headaches. Okay, so guess what? There are drugs that affect blood vessels that can be used for these vascular headaches and these migraines and clusters and whatnot. And these are derivatives of ergotamine. Okay, and they actually impact serotonin. Okay, and these include things like Imitrex. Okay, Imitrex is a very common ergotamine derivative that involves serotonin. It's non-narcotic. Okay, and in general, we don't like to treat migraine headaches with opioids if we can help it. We try to do non-opioid treatments. So Imitrex is one example. It's an injection, and a lot of patients will actually have a Imitrex injection that they keep with them at home. Okay, what's the next one? Tension. What's a tension headache? Yeah, this tends to be muscle. This is not vascular so much as muscle, right? And this can involve the face and the neck as well. Like you get spasms in your neck, and then that can precipitate this headache here. Stress may be a cause of this as well. Okay, what's next? Traction. What is a traction? What's going on with the traction headache?
It would be like related to something else, like
Okay.
stroke or
Maybe. It's kind of, yeah, traction's kind of very similar to tension, and for our purposes, these are somewhat interchangeable. The signs and symptoms are going to be very similar. And then finally, the fourth cause is inflammation. Now, inflammation headaches are due to some sort of inflammatory process. So this could be an infection. It could be, viral, bacterial. It could be due to a stroke. It could be due to blood being where it shouldn't be, etc. So, a headache may be a fairly benign, uncomfortable condition, or it may indicate something really bad.
So what would like the, fluids, which one would that fall under?
What do you mean?
Where you don't have water, dehydration,
Probably tension
tension?
would be more of a, but would fall more under tension or traction kind of headache.
Causing issues with the muscles.
Yeah, for sure. I lost my, severe. So what types of complaints should you take more seriously? Not that we don't take everything seriously, but. Yeah, so, first of all, if they say it is the worst headache ever, okay, if somebody says this is the worst headache I've ever had, or this is completely unlike any headache I've ever had, okay, you need to take that seriously. If there is a sudden presentation, in general, migraine headaches don't come on like that, do they? They develop over amount of time, right? Okay. If the patient reports hearing a sudden boom or clap, this is called a thunderclap headache, or a thunderclap presentation. Okay, this is sudden onset. That tends to be something like a Barry aneurysm rupturing and a sudden onset of a subarachnoid hemorrhage. That is a classic presentation for subarachnoid bleeding, is this thunderclap headache. Okay. If they have meningitis-like signs and symptoms, okay, so they have a very stiff neck, they have a fever, okay, they have the Brudzinski sign, all of that, okay, that obviously is very, should be taken very seriously as well. You guys okay with that? All right. So yeah, these are all much more concerning than your run-of-the-mill kind of migraine headache. Okay, very good. There's really not much else to talk about as far as infection. We've talked about the major baddies, the meningitis and the encephalitis. I think the next thing the book talks about are neoplasms. What is a neoplasm?
Tumors.
Yeah, tumor. How do brain tumors present?
Depends on the.
Yeah, it depends, right? It depends on the location. Okay, where is the tumor? How big is it? What is involved? Okay, it's going to be really hard to diagnose somebody's having a brain tumor out in the field. That's just the way it goes. Okay. Patients that are being treated for brain tumors, they are often on medications that help with inflammation to help attenuate ICP changes, so steroids. It's not uncommon to see patients that are being treated with a tumor of the brain on a steroid. Some brain tumors are very devastating. Others may be treatable, very treatable. Astrocytomas, for example, pretty devastating. I believe, you guys familiar with a lady by the name of Udi Phoenix? She was our state licensing coordinator for many, many years. Or Uda, yeah, Udi. I call her Udi because it's UTE, I think is, Udi, or Uda Phoenix. And she just died less than about a year and a half ago. Yeah, and she checked herself into the UNM one night, had a headache. That's all it was, just a headache. And they did a CT scan on her, and she had a large astrocytoma. They attempted surgery a couple times, and it's very aggressive. cancer, and she ended up dying a little less than a year later. Yeah. She was back at work, though, pretty quick. I don't know if, I got to see her after, while she was fighting it, and she actually had facial droop and all that due to the surgeries and where the tumor was pressing on her. Yeah, so bum deal. It's pretty sad, but yeah, these are going to be really hard to diagnose out in the field for sure. And then finally, that brings us to some other neurological disorders. Probably some of the most common ones are what we call our demyelinating disorders. This tends to be an autoimmune problem where the body's immune system attacks the myelin. Okay, and the classic disorder that we see, and it's a relatively common disorder, is what? Multiple sclerosis. Good. Multiple sclerosis has multiple different types. Relapsing, remitting tends to be a very common type. Some types of multiple sclerosis responds to treatment very effectively. Other types do not. These patients can have periods of time where they're not doing well, and then other periods of time where they are doing well. And with MS, this tends to be movement, right? Tends to demyelinate neurons associated with movement, so they can have a hard time walking around. They can have visual changes as well. Okay, you can have like temporary loss of vision, dizziness, vertigo. And like I said, this can kind of cycle, and they can get better, and they can get worse. And every MS is different. Every patient with MS is going to be very, very different.
Got a guy at work, a buddy of mine that has MS, and he initially presented like Bell's palsy.
Yep.
And then got on his MS, and they started treating him with like freaking random shit like flu. Like they would inject flu virus into him. They would give him like bee venom, stuff like that.
Just to try to
change that.
modify the immune response. Yeah.
To attack something else.
Sometimes it works. Yeah. Sometimes it works. Sometimes
it worked for like a year
yeah.
or so.
Is he still working?
Oh yeah.
Yeah.
Yeah, he actually just passed the EMT and stuff. He's on duty. So.
Yeah. Some people can do quite well for many years. It's just really, it just varies so much. And we talked about not a demyelinating disease, but a motor neuron disease yesterday, where the motor neurons, in your motor cortex die off for reasons that we don't understand very well. And the classic example of that is ALS, or Lou Gehrig's disease, amyotrophic lateral sclerosis. That is not a demyelinating disease. That is actually a loss of the motor neurons. People with ALS tend not to live very long, right? Because what happens, they tend to lose the ability to breathe, right? And then they get very compromised, and they die of things like pneumonia. Yeah, so they tend not to live very long. Some people do live very long, and like Stephen Hawking. Although it is somewhat debatable now as to whether we think that he actually has ALS. Some people think that he may have some other type of motor neuron disease because he's lived so long, and that's not what we see typically with ALS. So there are lots of these diseases out here for sure. There are some movement disorders as well. There's something called Huntington's chorea. And what is chorea?
Your eyes.
Hmm?
Your eyes. It's involuntary muscle jerking.
Yes, it is jerky. Yeah, chorea. Jerky muscle movements. And these tend to be kind of jerky, random movements. Okay? And somebody that has Huntington's chorea is probably one of the more common ones. This tends to be progressive, untreatable. Huh?
It's fatal.
It is fatal. It is ultimately fatal, yeah. Okay. There's not a whole lot we can do about it other than realize that they're going to have these movements and kind of work around that the best way possible, that these are involuntary. Yeah. There's also another type of movement called dystonia. Specifically, I want to focus on what's known as a dystonic reaction. It's a group of muscle disorders associated with dopamine. Dopamine is a very important neurotransmitter when it comes to movement in the central nervous system. Not peripheral, that's acetylcholine. And loss of or blockade of dopamine receptors in the movement areas of your brain can lead to or precipitate what's known as a dystonic reaction. Okay? And so drugs that block dopamine will increase the risk of this type of problem.
I had that after chemotherapy.
Yes. So your old school antihistamines, okay, like promethazine, okay, guess what? Promethazine blocks dopamine receptors. And it blocks dopamine receptors in the vomiting centers of your brain, which is one of the reasons that it is an effective antiemetic agent. But it can block dopamine receptors in other areas of the brain as well, and so it can precipitate a dystonic reaction.
Oh, that's what
Yeah.
black
But it's
box.
not pleasant.
What's that?
It's not pleasant,
It is not. It is very distressing.
and it's tiring.
Yes, it can be very painful, very distressing. Thorazine. Thorazine is an old school antipsychotic. We call it an old, and actually promethazine is a derivative of thorazine. So thorazine was one of the first effective drugs that were developed for treating schizophrenia, for example, psychosis. And guess what? Promethazine is a derivative of thorazine. They have very similar mechanism of action. They block dopamine. Okay. Other types of antipsychotic agents like Haldol. Okay, Haldol or haloperidol is a very common one as well. And anybody that takes a first generation, or we call a typical antipsychotic, is going to be at higher risk for a dystonic reaction. And in some cases, fairly rare cases, even other drugs like Zofran or Dancitron have been known to precipitate a dystonic reaction. Although it's
My understanding with that is that they push it too fast.
not even necessarily. It's just some people can go on and develop it. Because like Zofran was originally designed for cancer patients, right? And they get a lot more. I mean, you give like 30 or more milligrams of Zofran to somebody getting chemotherapy in a sitting. Massive doses, and a lot of them do just fine. Now, if you do push Zofran very quickly, yeah, you can run into issues, but it's pretty rare, though. At least it's pretty rare with Zofran. It's much more common with these particular agents here. And there are different types of dystonic reactions. There's something called tardive dyskinesia. You guys ever heard of that? Tardive dyskinesia is where you kind of get this, and you've seen taking care of patients that have chronic psych illnesses. You see them kind of walk around town, and ever seen somebody like that? They had a tongue movement in their mouth, and they kind of doing that kind of thing, right? That's tardive dyskinesia. That's one type, but the dystonic reaction, there are several things that can happen. You can have blepharospasms, spasms of your eyelids, spasms of your face, spasms of your neck muscles. You can have something called an oculogyric crisis, where the muscles to your eyes are spasming. You can have lots of different things that fall under the umbrella of a dystonic reaction. How do we treat somebody having a dystonic reaction?
I had to write it out.
Supportive care. And believe it or not,
Can you give dopamine?
right? Because, well, if we can give dopamine, but won't get to the central nervous system.
Right, you can't.
Yeah.
Benadryl.
Benadryl. Diphenhydramine has been known to improve the presentation of a dystonic reaction. So in general, we do recommend a dose of diphenhydramine. Can be very helpful. for some patients having these dystonic reactions. Very common in patients who take psych meds, though, okay, to see that. If you and I'm surprised none of you have seen that. No, I'm surprised because there's so many psych patients in this area that.
I've
Yeah.
treated one recently.
Okay, yeah, it's pretty common. It's pretty common in patients that take these antipsychotics. Okay, let's see here. We talked about ALS. Peripheral neuropathy. Well, we talked about this a little bit in cardiology. This tends to be diabetics, right? And what is peripheral neuropathy? It is damage to the peripheral nerves, specifically sensory nerves. Uncontrolled diabetes is a big cause of this, and this causes that pins and needles, shooting numbness kind of pain. It can be painful and numb and prickly pins and needles all at the same time, and that's known as neuropathy or nerve dysfunction. Okay, it's very problematic, and it can make you prone to infection because you may not be aware that there's a problem going on, right? Because you may have decreased sensation to that area. Okay, I believe we talked about Bell's palsy already yesterday. Not a whole lot else to say about that. There is something called myoclonus. Myoclonus, and what is myoclonus? Okay, it's an involuntary jerking, and you probably all have experienced this. So when you're going to sleep at night, has anyone ever had this experience? As you're going to sleep, and then you feel like and you go like that.
Yes.
That's a myoclonic. That's a kind of jerking, right? You feel like the elevator's falling,
Yes.
right? Right, and you have that's a kind of a myoclonic. Everyone's kind of had. I imagine most of you have had that happen, right? Yeah. Where do we see myoclonus become a problem? We're going to talk about this in more detail in the special populations block, but we see this with, not so much geriatric, but pregnancy, okay? This is a feature of eclampsia and preeclampsia, okay? Somebody who develops eclampsia, okay, has a hyperactive nervous system, and they will develop what's known as clonus or myoclonus. And one of the ways to test for myoclonus is to assess the deep tendon reflexes. You guys should have all done this in your intro class, right? The common one is the patellar reflex, right? You guys should have all done this in your intro class, right? So you hang their knee over, you hit the patellar tendon with a hammer, the end of your stethoscope, and what happens? Your leg goes like that, right? Boop, like that. So what happens is, when you hit the patellar tendon, there's a signal that goes from the tendon up into the brain, into the motor center of the brain, right? And then the motor center of the brain sends a signal down that says, contract. But then there's another center in the brain that's like, oh, wait a minute, no, we don't want to contract, cancel that. And so instead of giving a kick, you just get a little like that, and then there's a cancellation, right? And interestingly enough, we don't have a really good idea of why these types of reflexes even exist. What the evolutionary advantage of them is. It's one of those weird things. So what happens in somebody that has myoclonus is that inhibitory center does not work. And so when you hit their patellar tendon, what happens is
You'll get kicked.
you won't get kicked, but their leg will do this.
It'll go sideways?
No, not sideways, it'll move, right?
Moving.
So instead of getting hit and you go boop like that,
Right.
it'll just keep going. Right? And that's myoclonus, right? That is, and so when you see that, especially somebody who you're worried about having preeclampsia, you should check their deep tendon reflexes. And when you do that, and you see that movement continue, that tells you that's somebody who has a overexcitable nervous system, and that's somebody who's going to be at very high risk for developing seizures, eclampsia. right? Seizure, coma, death, right? That kind of stuff going on. Does that kind of make sense? All right. Let's see here. I think the last two things it talks about are spina bifida and polio. Polio is not something we see in the United States anymore. We thought we might be on the verge of eradicating it, but it's actually made a comeback in the Middle East specifically. But basically what it is, it's a virus that attacks the nervous system, and it attacks a lot of your motor neurons. And so people with polio, some people just recover from it just fine. Other people develop a post-polio syndrome where they may be unable to walk, and it may be even they may be unable to breathe as well. And back when polio was a big problem, back before we had ventilators, what did we have? We had negative pressure breathing devices. So the only way to get somebody to breathe is we'd put them in this large circular tube, and then we'd seal their neck around, and then the pressure in the tube would become negative, and that would force their chest wall to expand, and then it'd become positive, and then it'd contract, and that's how the patients would breathe. That was called an iron lung. And then once ventilators came around, of course, there are still, I think, less than a dozen people that are still in iron lungs in the United States to this day, believe it or not. So it's still just barely hanging on, but most people, we put them on ventilators. We trach them, put a tracheostomy tube in, and then they're on a ventilator. But occasionally, I don't think there are any iron lungs in this area of the country, however. So it's very unlikely that you're going to run into that. You guys okay with that? The poliomyelitis, post-polio syndrome. And then the last thing that I just want to mention, and this is more of a pediatric issue, is spina bifida. And spina bifida belongs to a group of neurological disorder known as neural tube defects. And the reason they're called neural tube defects is these are problems that arise during fetal development. And what happens is during fetal development is a little tube of tissue, a little tube of tissue, I think it's near the end of the first trimester, thereabouts, develops. And then from that tube of tissue, the forebrain, the hindbrain, and the spinal cord fully develops. And you can get defects in that. And one of these defects is something called spina bifida, where essentially what is that?
The tube isn't closed.
There you go. Yeah, the spinal cord actually, it doesn't get enclosed, and it actually is outside of the body. And so these babies are born and they have a spinal cord outside of the body. This tends to be a pretty problematic issue, as you might imagine, because why? Yeah, so they tend to have lifelong problems. There are surgeries that can be done, but if there's damage to that spinal cord, there's nothing you can really do at that point.
It's literally like out
Yep.
of the body.
Yeah.
It's not like on,
Yeah, it's literally, yeah.
I don't know, I'm going to.
Yeah, so if you're on a delivery and you see somebody with this, and it may be like a bubble or the spinal cord or tissue kind of outside. It can have many different presentations, but what do you do? Well,
Protect it.
just protect it. Yeah, moist, sterile, wet dressing. Protect it, minimize trauma to it, don't move them, and get them transported to where they need to go. And that's really all we can do for that. And that brings us to the end of neurology, the end of all the major